Hello everyone, thank you for joining us for the October Provider Workshop. This evening we are here to introduce you to Dr. Andrew Jonassen and Dr. Darin Allred, orthopedic surgeons for Memorial Hospital of Carbon County. As part of our ongoing focus to enhance services available to the residents of Carbon County, we have committed to expanding orthopedics and will be sharing more about this exciting growth with you tonight. Please join me in welcoming Dr. Andrew Jonassen and Dr. Darin Allred. Dr. Jonassen, we'll let you go ahead and start.
Okay, well, hello everybody. I'm Dr. Andrew Jonassen MD. I'll just tell you a little bit about myself. I was recruited to work in Rawlins as a full-time orthopedic surgeon at Memorial Hospital in Carbon County, and I moved to Rawlins and began working at MHCC in July 26, 2021, this year. I'm here to provide orthopedic care of injuries, including fracture care, and to treat arthritis, including joint replacement, hip and knee especially, bone disorders, including osteoporosis treatment, and other general orthopedic problems. My background is different. I was actually born in London, England, in the UK. But just after being 1 year of age, my family moved to Canada, and I've actually been raised or grew up mostly in Western Canada. It's actually very similar in many ways to Wyoming, Colorado, and the Rocky Mountain region. I grew up in Calgary, Alberta, and I played a lot of sports growing up, and I obviously saw injuries pertaining to sports. And in high school and college, I played varsity football and rugby, and I also skied competitively in downhill skiing. And then after college, I ended up playing professional football for 6 years in the Canadian Football League. While I was doing that, I was actually attending medical school, and I did my medical training in Canada at the University of Calgary. And after that, I also did my orthopedic surgery training in a residency there. Shortly after completing my orthopedic training in Canada, I did a fellowship, they call it, which is post-residency training in orthopedic traumatology, and I did that in Seattle at the University of Washington for a year. And I also did training in joint replacement in Denver, Colorado. And so really my medical training has been in both Canada and the US. I was board certified in Canada as an orthopedic surgeon, and I've been board certified since I finished my training in the United States. My background as far as practicing orthopedics and practicing in the US is I practiced almost all of my orthopedics in the United States, and mostly almost completely in Colorado, as well as now starting to work in Wyoming. I was recruited to Denver and the University of Colorado originally to join the faculty and work as an orthopedic surgeon at the Denver General Hospital, which at that time is now called Denver Health, and it's a level 1 trauma center. So I was doing high-level fracture care, as well as doing joint replacement at the University of Colorado. I was an associate professor there and continued to teach orthopedic residents as well as medical students for about 12 years. After that, following that, I actually went into private practice, and I continued to practice in the Denver metro area until 2012. At that time, I decided that I would try something different, and I went to a similar type of hospital that we have here in a mountain town, Salida, Colorado, with a smaller population but the same size hospital, 25-bed hospital, which we call a critical access hospital. And they at that time wanted someone to come in full-time to do joint replacement. And I started a joint program there for both hip and knee replacement. And I practiced there for 8.5 years, up until this year. And I decided after seeing some information on Rawlins and that they were looking for an orthopedic surgeon. I came here and I really loved to see the hospital and the community here, and it was very similar to what I had learned to enjoy in Colorado, which was a rural type medicine practice, hospital-based, where I could once again do some development of, or more development of joint replacement and do fracture care and other orthopedic care here. So there has been joint replacements being done here, and I wanted to see if I could make a difference in terms of increasing the numbers of people we treat for arthritis, and that includes surgical treatment with joint replacement. So I'm looking forward to developing that here, and I'm certainly happy that I'll be working with Dr. Darin Allred here, who has been performing some joint replacements as well as sports medicine surgery for ligament tendon injuries and other sports injuries.
All right, great, thank you, Dr. Jonassen. So we're going to go ahead and turn it over to Dr. Darin Allred at this time, who is joining us virtually this evening. Dr. Allred, can you hear us okay? All right, there we are. Hello, Dr. Allred, can you hear us okay? We cannot hear you.
All right, how about now?
Okay, perfect. All right, Dr. Allred,
Okay,
thank you.
perfect.
Thank you so much for joining us. So, Dr. Jonassen just started us off this evening with an introduction about himself, a little bit of a bio. And so I'd like you to go ahead and do the same thing, and then at that point we'll go ahead and let each of you individually talk more about your services and specialties, and we'll entertain some questions from viewers.
So first of all, thanks for being patient with me. I'm driving through the desert of Nevada right now, and just barely got back into cell phone coverage, so thank you. I was born in a little small town in the southeast portion of Texas, little small town of about 7,000 people, and loved it. But then went on to medical school at San Antonio, and then Oklahoma City. Then I did my fellowship in San Diego, and then worked in Denver for 15 years, and then quite frankly just got a little bit bored with it, and then decided that I wanted to kind of go back to my roots, small town, and so now I travel to several small towns. I live in Salt Lake, but then I travel to small towns to do surgery, and I've loved it. I love it because I kind of get back to the patients the people I grew up with. I did my fellowship in sports medicine, which basically means knees, shoulders, anything with the scope and arthroscopy, ACL tears, rotator cuff tears. Being a small town surgeon is really fun because it stretches me. It makes me not do just the same 5 surgeries over and over again, but I get to do a little bit of everything, which is, as a guy that's really nerdy and likes challenging himself, has been really fun. Enjoyed Rawlins. I don't know if you guys have met Bob. He's been great to work with. And Dr. Jonassen obviously brings a wealth of experience, and that's been great. So that's my quick introduction.
All right, thank you so much. So Dr. Allred, since you are driving and things are a little bit different for you, I'm going to let you go ahead and move into, if you want to expand on some of the specific services that you provide.
Yes, and by the way, I'm not driving now, so I'm not going to die. But I pull off the side of the road. But I do pretty much anything orthopedic except for the complex joints. I'll tell you what I do really well is anything to do with the shoulder and the knee. And then foot and ankle and hand is stuff that I do. I'm good at that, but it's not my fellowship training. And then the other thing that I'm really interested and excited about is just carpal tunnel release, which I know is in the hand, but using ultrasound to do minimally invasive type procedures. The nice part about ultrasound is it's like arthroscopy, where we do minimally invasive, but you can see what you don't want to cut, and then so you can do it minimally invasive, so which means faster recovery, less pain. So, questions?
Okay. Yes, and we will move into some questions here. I guess I'm going to jump back over to Dr. Jonassen, and same thing, if you want to expand on some of the things that you specialize in.
Sure. Yeah, I was, as I said, I'm happy to work with Dr. Allred because of his expertise in the shoulder area. And we both treat arthritis in hips and knees, but he's obviously very well trained as well for knee injuries that are not yet arthritic, try to prevent arthritis. And so I practice both types of approaches to medicine as well, which is partly preventative to help prevent worsening of joint function and worsening of arthritis, as well as treat the arthritis that has developed with techniques that are going to help restore function and to mainly get rid of pain. So in that regard, it's mostly joint replacements. When you get joints that are worn out and require something done to get rid of the pain, stiffness, and swelling in the case of a knee or an ankle, that type of thing. So my experience has been fairly extensive in the hip area because I did a lot of traumatic hip injuries with acetabular fractures and pelvis fractures. But the hip replacement process that I've gone through has been, since being trained as a resident and a fellow in joint replacement, has gone through some really important changes over time. And I've tried to keep at the cusp of the newer techniques that have been shown to be very effective. And one of the most effective things now is that people are in hospital a lot shorter time, they're functioning more quickly, and they're getting back to work and back to recreation more quickly. To help that happen, of course, there have been changes in techniques, including the anterior approach, posterior approach, and changes to the actual implants that we use. And I tend to use implants now that are almost always cementless. We will use some cemented implants in people that have poor bone quality. They have a lot of osteoporosis. We tend to use those mostly in the elderly who have broken their hip. And one of the reasons they've had a broken bone in the hip is because of osteoporosis. But for most active adults who are past working age and retirement, but still want to keep active and are active doing recreational activities, we use implants now that pretty well maintain normal motion and allow all activities, including, we let people ski, we let people swim, obviously, people hike, people do sports that are not going to cause falling or some damage to their bone and their implant otherwise. And it's the same for knee replacements that have now become, through innovative design and treatment, become more reliably successful, over 90% restoring good function without pain and with high levels of activity allowed. And along the same lines that we both work in, both Dr. Allred and I, is types of tips that are unlikely to dislocate, unlikely to restrict activity. And our approach is to let people return to normal activities and basically normal recreation within 2 months to 3 months of surgery. They can walk immediately after surgery and can begin activities of daily living on a pretty and return to normal activities of daily living by 2 to 4 weeks. The program that we use to help the patient be able to move sooner and get back to more normal activities more quickly is also based on improvements in pain control at the time of surgery and after surgery. We use now agents that block pain for up to 3 days after surgery. We use different medications now to try to avoid opioids and other medications that tend to make people less active. And with proper rehabilitation, restore normal walking activities and other activities within a few weeks. Healing is improved because of our techniques of trying to preserve tissues better without cutting through important tissues and try to avoid larger wounds and incisions to heal. And in terms of the knee, one of the biggest advantages that have occurred in the last decade or so are knee replacements that provide good function, meaning almost full range of motion, but still give good stability to allow people to hike and go up and down hills and to cross slopes that are on angles, and to be able to step over objects and things that they may encounter during hunting in the mountains, walking in the mountains, hiking, and even activities that allow them to ride mountain bikes and equipment like that. So in terms of experience, I've obviously been doing hip and knee replacement for several years, over 25 years. I've used mostly a posterior approach recently. However, I've done anterior approach and posterior approaches. Both approaches are minimally invasive, but they tend to give similar results, certainly within a few weeks to 6 weeks from surgery. Activity level and complication rate is about the same. So we can do both. In terms of the total knee replacements, we will try to determine after trying methods to control arthritis, pain, and function without surgery. I try to suggest specific implants that might help the patient. If it's not needed to replace the entire knee surface, we can do partial knee replacements. I've done several kneecap replacements without the rest of the knee being replaced. And we also do obviously total knee replacements. And all of these replacements have shown high levels of success and longevity. Currently, our total knee replacements are lasting 20 to 25 years. Rarely do we have much complication with blood loss, with infection, or with stiffness. In terms of the hips pain is usually less than knee pain after surgery, and our hip replacements have done very well with no dislocations in the last 7 or 8 years in my practice, and no infections for over 5 or 6 years. So techniques of improvement in terms of prevention of these complications, as well as new techniques and instruments that give better results, is what we try to practice.
Great. All right, thank you.
You're welcome.
So if someone is considering surgery, you've both mentioned multiple different procedures that are available here in Rawlins at this point. So if someone is considering surgery, two-part question: what is the first step? And then in addition, what are some things that people can do in advance to prepare their bodies for surgery? Are there some recommendations that you would give regarding that?
I could go ahead.
Either one of you can answer.
Sure. Well, I think for the more, the larger surgeries that we just mentioned, replacements, joint replacements, there is a protocol we use, and that's based upon best practices, and it's been shown by large centers like the Cleveland Clinic and Mayo Clinic and other areas, other types of facilities that have high volume, that if you follow these protocols, the complication rate and the recovery rate is improved. So in preparation for a big surgery like that, we have obviously medical clearance to be sure there aren't any serious medical problems that might involve heart, lungs, kidneys, that could complicate the procedure. We do preparation of to prevent infection now by using antimicrobial wipes that go over the skin area around the surgical site before surgery. And then we employ different techniques during surgery now to reduce the chance for infection. And one of the things that I'm doing in the knee replacement area is taking instruments that are actually disposable, and they're sterilized prior to surgery, and they remain sterile until we use them. And that lessens the need for sterilization in the hospital, lessens the need for wrapping of instruments where there can be a chance for infection occurring. And I think that's been one of the reasons why my infection rate has been zero for the last 5 or 6 years. And I also think that sticking to eliminating any chance that the patient may have infection in their body or in their teeth or in their mouth before surgery, it also helps prevent spread of bacteria to a metal or artificial joint where it's much easier to get an infection. In terms of other preparation for other types of surgery, generally it depends on how invasive the surgery is and how likely complications can occur. Our blood loss has been minimal, but we still check people's blood levels and make sure they have adequate hemoglobin. We check other things like breathing ahead of time and make sure there won't be any complications from a surgery that is what we call elective. Joint replacement surgery and a lot of our surgeries are not absolute emergencies. And if you have higher risks, then in our hospital, which is a critical access hospital, we would probably be referred to a center that has more medical support than we have. But for most patients who are relatively healthy and are undergoing surgery at our hospital, as long as these areas are checked into beforehand, results are very good.
All right. Is there anything you'd like to add to that, Dr. Allred?
I would. I agree with everything that Dr. Jonassen said, but just want to add that the most important thing to prevent, or not the most important thing, but one thing that you can do is just remember that the healthier you are going into surgery, the less likely you are to have a complication. So that includes no smoking and managing your diabetes as best as you can, and really and exercise and pre-surgical physical therapy. All those things can add a lot to your risk and to the ease of your recovery.
All right, thank you both. What about trauma surgical procedures? Is that something that that is an option here locally? Is it something that you perform?
Yes, it is, and that's the other part of the program here. I think can be developed further. We have the ability, and we have been doing. I have been doing since I arrived. Fractures that involve the lower limb and upper limb. We are able to do these surgeries now on a reasonably urgent basis, meaning within a day or two of the injury, which then has made it so people don't have to go elsewhere. They can get it here in the Rawlins, at the hospital. Our hospital is currently also obtaining more types of equipment that we need to increase the types of cases we can do. But for most people in this area, if they break an ankle, break a wrist, break a long bone in their upper limb or the lower limb, can be fixed at our hospital. There are some types of more severe injuries that we can't fix at our hospital, partly because of our classification. If somebody has multiple injuries, then that patient would be treated at our hospital. If there were injuries to pelvis, spine, areas that really require expertise to fix in that area by subspecialists, that wouldn't be something that we would normally be able to treat at our hospital. But other types of common breaks we treat now, and we'll continue to treat them surgically with fixing the bones as needed.
Great, wonderful. All right, so our next question, Dr. Allred, I'll let you start, and then we'll reverse and let Dr. Jonassen follow up. You're both very experienced surgeons and have practiced at much larger facilities than MHCC. How would you describe the surgical facilities here locally? What's been your experience?
To be honest with you, I was shocked. I was pleasantly surprised. I worked at a lot of small facilities, and your facility there ranks at the top of those facilities. And honestly, your staff ranks right up there compared to some of the bigger cities I've been in. You know, there's something about, at the end of the day, the OR is basically comes down to a handful of people. And the closer you are to that group, the better you know them, the better you work with them, and the easier things flow. So honestly, it's been really a true delight to work there. I'd take your hospital or crew any day over my Metro Denver crew.
Okay, great. Dr. Johnson?
Well, I've been here only a short time, but I'd have to concur with Dr. Allred. Yes, I think that I was, one of the reasons I came here from a previous facility similar to our hospital here was I was quite impressed with the size and the availability of the operating rooms here. We're a small hospital, but can do a lot of very different types of surgeries, and I don't think the actual operating space or the hospital itself is restricting us from doing anything. It's based more on other issues. So I think the operating room is clean. It's very well run, and I think that I agree with Dr. Allred. Our staff here are very good to work with as a surgeon.
All right, thank you. Let's see, what about pediatric patients? What type of options are available for pediatrics? I guess probably specifically it would be more of along the lines of trauma.
Yeah, well, we do treat pediatric fractures here. I've treated several since I got here. Majority of the breaks don't require surgery. There are some types of surgery, again, that because of the pediatric population might be a more serious injury that we may not be able to take care of here. If it looked like the type of break they have requires a specially trained pediatric orthopedist. But for most common injuries, common fractures in children, we can treat them here.
Okay. Dr. Allred, did you have anything that you wanted to add to that?
No, I would agree. Most pediatric patients are really the fun to take care of just because they heal so well. But they're definitely a subset of pediatric patients that are better treated in Denver or somewhere that has a pediatric specialist.
Okay. So let's go back to the knee replacement topic. That's certainly something that I think we see a lot of in our area just because of our active lifestyles here. Are there specific criteria for those knee replacements?
Are you? I guess I'd have to ask in criteria in that what type of problem they have that needs to be taken care of.
Yes.
Yeah. As I mentioned, there's areas of the knee that can be require, causing a great deal of difficulty for the patient, but it may not involve his entire knee, so partial replacement is an option. I think the other thing is that recently there's been great improvements, as I say, in the treatment of that. So whether we use navigation, which is using a computer and imaging to help be more accurate with how the knee replacement is performed, or what we call a pre-measured knee, or what they call patient-specific knee replacement, where it's done from a CT scan. The imaging we do determines the likelihood of the type of replacement we will do. And there is quite a large difference between implants based on how stable they make your knee make, or how stable they need to be to improve problems that might develop from, say, a bad fracture or trauma. There may be damage to ligaments requiring a knee replacement that is more stable, and then there are others where there haven't been any significant injuries to the patient, but they have arthritis, where we can use a knee that is stabilized by your own tissues and therefore is more natural. So I think these criteria are important to determine what type of treatment would be the most successful for the problem we're dealing with.
Okay. Dr. Allred, any other comments on that topic?
No, I would just say that really quickly, the knee technology is changing literally every day. And we've been doing them for what seems like a million years, and we keep making them better and better. And everybody always asks me, what's the best total knee? And my response to that is, it depends on the surgeon. It depends on your surgeon and whatever knee he uses. Just because each one is different. And so, for instance, I use a navigated total knee, and honestly, that basically means robots and trying to fit it all and correct soft tissue balancing and using a computer. But that's not any better, honestly, than a regular total knee in the right hand. So if you're asking what's the best total knee, it's probably the wrong question. The right question is, hey, what's the knee that your surgeon uses, and if you trust your surgeon, just go with that one.
All right, so we don't have any other questions right now, so I guess I would just open it up. Is there anything that either of you would like to add, and anything that you want our viewers to walk away knowing this evening about orthopedic services here at Memorial Hospital of Carbon County? And Dr. Allred, if you'd like to start.
I spent time taking care of the Sooners and the Padres, and I would much rather take care of people in Rawlins. They're way more fun. We both do our best to have a good outcome, and we both love it, and we both enjoy the process of being a surgeon, and it can be challenging, I'll be honest with you, at times. But we'll do our best, and we hope you guys have great outcomes.
Yeah, I would say that just to add to what Dr. Allred said, and to answer your question, I think the hope is that we'll continue to improve, and that's always our goal, is to maintain standards and improve in areas where we have a chance to do that. And I think now, certainly with the two of us here, I think this will also improve the availability of orthopedic surgery here, as well as I think the quality of the surgery. And I think that's what people want to know. They want to know if they have a problem, and can they go to their local hospital and expect to be taken care of well. And to reiterate what Dr. Allred just said, I think if you have surgeons who are have experience and good training, and they make decisions which seem to be based on those factors, hopefully we'll get good results, and people can trust at this hospital that they'll get good care, and probably pretty close to state-of-the-art care with with the things that we've mentioned, primary joint replacements, most fracture treatment, will practice at a level that's pretty close to state of the art. And I think with both of our experiences in these fields, there are most orthopedic problems can be taken care of here very well.
So consultations, if somebody wanted to schedule an appointment with you, what does that process look like? Do I need a referral from my primary care provider? What steps do I need to take if I'm interested in pursuing this further?
That's a good question.
I'll go.
Yeah, you go first.
Go ahead. Do you want me to go first?
Yes, please.
Since my situation is a little bit unique, since I'm not there every day. Certainly, you're welcome to make an appointment directly. Nobody needs an appointment. Most of the issues we deal with can be treated non-operatively initially, and our PA, Bob Keel, is fantastic for initiating that treatment. For those that need surgery, he's really good about identifying that and getting the right imaging, and then so he's a great place to start. Or you can make an appointment with me directly, either one.
Yeah, it's similar for me, and I'd say the same thing. The member of our team who's really important to the orthopedic department is Bob Keel, who is a physician assistant who's has been working at the hospital for some time in orthopedics. He will see patients as well, of course, and direct patients who need more consultation with us. I think that in terms of access to our clinics, I feel that people can get in probably within a short period of time, within days, to see one of us, and also shouldn't expect that they need to have their primary care refer them. We see many patients directly if they feel they have an orthopedic problem that they want to have checked and know what to do about it.
All right. Well, thank you both so much for taking the time to
You're
join us
welcome.
this evening.
It's great to be here.
And helping Carbon County residents get to know you a little bit better. The only thing I will add is that we have recently made a transition with our general surgery and orthopedic clinic, and that those services are now located at the newly acquired property directly to the west of the hospital, which is 606 23rd Street. So that is the location, and in order to contact them for an appointment, they can be reached at 324-6022. So with that, if you do have any questions after the workshop is ended, as always, feel free to submit those via our Facebook Live, and we will submit those to Dr. Allred and Dr. Jonassen and respond to you as quickly as possible. Thank you for joining us, and have a great evening.
Thank you. Bye.
Thank you.